Administering a blood transfusion involves introducing a massive volume of foreign biological material directly into a patient's circulatory system. It operates like a liquid organ transplant, carrying a high risk that the immune system identifies the donor tissue as a threat and attacks it. This simplified grid illustrates the biological stakes of blood compatibility. It maps out the ABO and Rh blood types, tracing the safe flow from O negative, the universal donor, which lacks the antigens that trigger an attack, all the way to AB positive, the universal recipient. To prevent a disastrous immune response, clinical protocols demand strict verification. At the bedside, two healthcare providers must physically double-check the patient's identification, their exact blood type, and their Rh status before a single drop enters the vein. Even with flawless initial verification, the human immune system can still react unpredictably. The first 15 minutes of the infusion present the absolute highest probability of an adverse event. 10 minutes into a transfusion, a patient suddenly reports intense chills and a tight feeling in their chest, followed by severe, throbbing lower back pain. Those subtle, early clinical signs indicate that the pre-infusion safeguards have failed. From this exact moment, the patient's survival relies entirely on the attending nurse recognizing the reaction and taking immediate action. The very second an adverse reaction is suspected, the absolute first operational step is to halt the flow of blood. Flushing the existing IV tube fatally pushes remaining reactive blood into the patient. Instead, disconnect the line. Use a completely new administration set, primed with normal saline at a slow keep vein open rate. This continuous infusion prevents vessel collapse, retaining a route for medications. With the lines secured, the focus shifts to assessing the patient's airway, breathing, and circulation, while simultaneously alerting the attending physician and the blood bank. Executing this universal stop protocol removes the biological threat and stabilizes the patient's vitals. That buys the critical time needed to decode exactly what kind of physiological attack is unfolding in the body. When patients receive incompatible blood, their antibodies attack and destroy the donor's red blood cells. This triggers an acute hemolytic reaction, marked by severe flank pain, bloody urine, and a rapid drop in blood pressure leading to shock. A more common response is a febrile non-hemolytic reaction. Here, the recipient's antibodies target donor white blood cells instead, resulting in a sudden spike in body temperature and intense shaking chills. If the patient is hypersensitive to specific plasma proteins in the donor blood, they can suffer a severe anaphylactic reaction. You will see their airways swell rapidly, accompanied by hives and audible wheezing. This image displays the precise measurement markings on a 1 ml syringe. Because an anaphylactic response closes the airway in seconds, you need this exact scale to measure and administer a critical emergency dose of 1 to 1,000 aqueous epinephrine. By accurately identifying these specific immune symptoms, a nurse shifts from providing generic stabilization to delivering targeted pharmacological rescue tailored to the exact threat. Sometimes a patient's primary symptom during an infusion is sudden, severe respiratory distress. Tracing the exact cause of the lung failure requires careful diagnostic work. This comparison table details two causes of lung distress. Left, TACO occurs mechanically when fluid is infused too fast, spiking blood pressure. Right, trolley is an opposing immune reaction where donor antibodies attack the patient's white blood cells, causing severe edema without volume overload. Distinguishing between a mechanical volume problem and an immune-mediated lung injury dictates the next steps. TACO requires diuretics to pull off the excess fluid, while trolley demands immediate respiratory support and steroids to calm the immune response. Once the patient is stabilized, the event triggers a strict forensic protocol. You must return the remaining blood bag, all attached clinical labels, and the entire administration set back to the blood bank for rigorous testing. At the bedside, you are absolutely required to collect the patient's very first post-transfusion urine specimen. That specimen is sent to the lab to test for hemoglobinuria. When destroyed red blood cells release hemoglobin into the bloodstream, it filters into the urine, turning it dark and signaling that acute renal damage is imminent. Handling a transfusion reaction comes down to strict operational discipline. Stop the blood flow immediately and never flush the contaminated intravenous line. Your diagnostic accuracy directly dictates patient outcomes. Carefully observing bedside symptoms allows you to separate a hemolytic crisis from a severe allergic response or a mechanical respiratory threat. Modern laboratory technology can cross-match blood types with incredible precision, but when foreign biological tissue enters a patient's body, the bedside nurse's vigilance during those critical first 15 minutes remains the ultimate failsafe, protecting them from a lethal complication.